welcome to today's training. And our topic for today is going to be Medicare Part C and Medicare Part D. All right, now Parts A and B are always purchased together. Okay, now you can have one or the other, but when you usually sign up, you usually get them both together. Okay, now Medicare will call these original Medicare. So to get Part C, there's a requirement that you have Parts A and B to get Part C. You got to have both of them. And the actual wording that you'll see in the literature is entitled to Part A and enrolled in Part C to get Part C. Then when it comes to Part D, you can have A and or B. So it doesn't have to have both of them. You can have A, you can have B, or you can have both. Okay, so it only requires that you have one of them in order to get the prescription drug plan. So most people get Part A, premium-free Part A. I mean, if you don't qualify for premium-free Part A, you can buy Part A. If you have to buy it, that's going to be $458 a month. Typically, those who have to purchase Part A fall into one of two categories. One, they were a trust fund baby, they never worked, or they never managed to get their 40 quarters of work to get premium-free Part A. Now, the other group, which is kind of the same thing, but it has a unique characteristic, is that they're typically people who immigrated to the U.S. later in life. In other words, they never had the opportunity to work here. They did move here. They did become a legal status. They've had their legal status for 5 years. That's the qualifying time period to be eligible for Medicare Part A. So that doesn't even give you enough time to work your 40 quarters, right? So you have to have 40 quarters to get it at premium free. If you only got 30 quarters, you do get it at a reduced cost of $252, but usually they don't work at all, and they have to pay the $548. Deductible, remember Part A does have that deductible. Per benefit period, $1,464, and Part B deductible is $203 this year. Don't know what it's going to be here for open enrollment. Okay, the Part B premium, while it is income related, most people pay the $148.50. So let's jump into Part D first, and we'll break apart Part D and kind of look at how that was put together. One of the things that I usually like to drive home right up front is that Part D plans typically are freestanding and they're sold by private insurance company, but they're all different. Okay, but they all follow a basic Medicare Part D plan. Okay, so Medicare Part D beneficiaries with an income above a certain level, will still have to pay their Part D premiums. It can be subject to your income, and so there can be what they call the income adjusted amount. Income-related monthly adjustment amount, known as Part D IRMA. And then most of these plans charge a monthly fee, which varies by coverage. And in addition to your Part B premium, those covered by a Medicare Advantage plan or Part C may have coverage into that plan. Yeah. We'll look at how extra help can come in and help out. But these are the two. Now, when you do get that Part D as part of an MA plan, it's built into the plan, but it is separate coverage. You can have its own drug deductible separate from the medical deductible. The out-of-pocket limit that you see on the MA plan does not pertain to the prescription drug portion. So it is actually a separate plan within your Medicare Advantage plan. And we'll talk Medicare Advantage here in a bit. Now, as I said earlier, Medicare Part D plans are freestanding, and they're sold by private insurance companies, and they can be part of your Medicare Advantage MAPD. But just to be clear, there is no government Part D. I mean, like we have Parts A and B where I can actually get those from the federal government. There is no Part D that I can get from the federal government. CMS was going to provide a model that the plan must meet to be as good as to be considered credible coverage. And that's a term that you need to be familiar with. Credible coverage, meaning that your plan meets this model that we're about to discuss. So we're going to look at the parts of the Part D model. Quite simply, the foundation of choosing a plan starts with checking each member's prescriptions and going from there. Some plans do include enhanced Part D coverage. Now, here's the minimum. This is what the model says. You can have a deductible, but that deductible cannot be any more than $445. That's the maximum deductible you're allowed to charge in your plan. You'll have an initial coverage limit. So in other words, I meet my deductible. I can be now making co-pays, for my prescriptions until I reach $4,130. Now that's again, we're going to go back to, we'll be talking about the true out-of-pocket, but this is all the money spent by you in the plan towards the prescription. So I may only have paid, a $35 copay, but the drug could have been $400. So that's what they're going to be tracking, is that total cost, not what I paid. Then once I've reached that initial coverage limit, I'm into what was traditionally known as the donut hole, but it's not quite the same as it used to be. Now, in the donut hole, the customer will pay 25% of the cost for both generic and brand name drugs. So they'll simply be 25%. Now, once that true out-of-pocket, remember that's what I paid, what the insurance company paid, what any discounts were included in there, etc., reaches $6,550, I'm now in catastrophic coverage. Once I reach catastrophic coverage, my payment will be much different. It'll be much less. This is just another way of looking at it. And this is kind of the old traditional, because it would have been known as the donut hole for so long, kind of keep that concept simply never went away. So this kind of shows you in the deductible phase. You pay until you reach $445. That could be one prescription. That could be, multiple prescriptions. I mean, all I'm taking, and this is something that you're going to need to get used to, is looking up all these drugs. You're going to find that there's some very common ones out there that are just generic and they're very inexpensive. And that's going to be the typical blood pressure pill, a typical cholesterol pill, some kind of, upset stomach gastroenteritis type pill that people have. Other common ones are going to be, for thyroid. But get kind of used to looking those up. You'll start recognizing the names as you go from customer to customer. Typically, they're generic and they're very inexpensive. In fact, you'll have people saying, "Why do I need a plan? I'm only paying $4 or $5 per prescription anyway." We'll talk about the penalty later on as why they want to get the plan. So now you can tell you've met your deductible. Then you'll enter the initial coverage phase. So now you're usually paying that, $35 for the $400 drug, right? That's what people would keep in mind in there. Maybe I need something like an EpiPen, which could easily cost, under the brand name, it could cost over $400, but I'm only paying $35 copay for it. And so as they're tracking that along, once the total cost of the drugs, not just what I've paid, but what I and the insurance company have all contributed to, reaches that $4,130. Now my price changes. What I was once paying a simple copay of maybe $35 for my $400 drug, I'm now paying $100, right? 25% of the cost of that prescription. And then when all of those costs totaled up, reach $6,550, I'm in the catastrophic, and I am paying 5% of the cost. I always like to point out now there's some drugs out there that are incredibly expensive, and my 5% can still be $800-900. Okay? So what is a person to do? There's a couple of different things that are available, and it starts when somebody enters the gap. If I've got that $9,000 drug that I have to take, 25% of the cost is still right $225,000, something like that. So I mean, 2,500, I should say. So it's still quite expensive, and I'm looking for relief in there. I'm going to have a couple of sources. We're going to be talking about one of them, which is extra help, and the other is I can contact the company and see if they can help out with some costs for their product. And that catastrophic, like we said, 5%, or I could be making a copay, and it's whichever is greater. So it's $3.95 if it's generic, or $9.35 for something that is maybe a name brand. Okay. So there's some cost control measures that have been allowed to be incorporated into the plans. I always like to point these out because this is one of the favorite areas that secret shoppers like to have, to see if you're going to explain just how these drugs work. And the lead in under the secret shopper would say, "Hey, I just want to know what looking at drug plans, they'll rattle off 3 or 4 prescriptions. They want you to look them up, and usually they'll fall between some tier 1, tier 2, tier 3. But what they're looking is that you mentioned these cost savings methods that have been allowed to be incorporated. Prior authorization. On there it'll say PA for prior authorization, and the doctor must have permission from the drug plan to prescribe certain drugs. And if it's one that has a PA on there, and it doesn't mean that's going to stop them, right? I mean, the drug's covered under the formulary. They just want the doctor to contact them first to get authorization to prescribe the drug. And that's not only on the initial prescription, but then the pharmacist will need a prior authorization to fill the prescription. So my words to most of my customers, if it's got a PA on there, don't take that last pill before you go down and refill it, because it could be up to 48 hours to get permission. especially over a weekend, computer is down, upgrades are happening, don't count on being able to grab that right away if it's got a PA on it. Another one that you'll see is quantity limits, QL. Dosage may be limited per month. The doctor can request different quantities, but you'll see this on expensive drugs. Where they want to make sure that you don't get more than maybe a 30-day supply at a time. Or it could be on something that is a controlled substance, in which case they may limit it to 4 days worth, 5 days worth at any one time, and that the doctor would have to rewrite the prescription at the end of that. Okay, so that you can't just stock up on oxy. Okay? And that third one, step therapy. Step therapy usually will be found on drugs that are expensive, for which there are less expensive alternatives to that same drug. Perhaps there'll be a name brand and a generic. And so what the company is doing is requiring you to try the generic before they will and see how it works. So, through your doctor. It's not like it's just the company working with you. They're working with you and your doctor, and they'll tell the doctor that you have to try a certain generic before they will approve the name brand. So that's step therapy. Okay. Now, when it comes to formularies, I'm usually looking to help people understand these questions. All the drug plan formularies the same? Well, no, they're not. And that's one of the reasons we have so many different plans out there. Okay. The rule that they have to live with is that for every therapeutic category, there must be a minimum of 2 drugs. In other words, if that therapeutic category is insulin, you must carry a minimum of 2 insulins. And so we ask, why are there so many different plans? Well, because there are so many different drugs out there. Some plans would contain all the insulins. Some plans would only list 2 of the insulins. You can envision that the one that covers all the insulins would be far more expensive than the one that only covered 2 of them. Now, if Medicare approves the drug, is it going to be in every company's formulary? Well, the answer to that is no. Just because Medicare approved it, if it was the 10th drug in a therapeutic category, the plan doesn't have to cover it. Remember, its requirement was only to cover 2 in the formulary. Now, just because a drug is very expensive does not mean that they won't cover it. If Medicare approves it, then it's going to be available to go into the formulary, right? Because there are drugs that are not allowed, right? You can't put vitamins in the formulary. You can't put any kind of cosmetic, such as hair growth, drug in the formulary. So there's a lot of things that can't be covered. And so why do these prices vary so much? Well, if I have the plan that's got, all the insulins on it versus one that only has 2, there's going to be quite a difference in price. So that's what we're looking to understand, is that I need to look up my customers' drugs, every one of them, and see what plan would cover those. Now, for a drug that's quite expensive, maybe $400 or $500 a month, and it would be nice to have a copay of $35 to fill that drug, versus having to pay the $500. You could see that I might want to pay $75 a month for that plan. That would save me from the plan that didn't contain the drug at all, and I had to buy it out of pocket. So you can see that's why we have such a variation in prices. Yeah, I always like to use insulin because you can see here, if I go to rapid acting, there's 3 of them. Short acting, I've got 2 of them, right? Intermediate, I got 1. Long acting, I've got 3. And a premix, I've got another 1, 2, 3, 4, 5, right? So I'm unlikely to find a plan that's going to contain every one of these. So you look at that first one up there, that therapeutic category, rapid acting. The first 2, I've normally seen a plan either have Humalog or Novolog, not both, one or the other. And then you'd see there's the 3rd there. Now, that doesn't know what you would typically find is one of them is the preferred, tier 3, and the other one would be tier 4, non-preferred, kind of really driving, the sale of one particular. So you can see how that would work. Now, if I go over here to the short acting, it's a little bit different from the rapid acting. I'm not an insulin taker, so I don't know that for sure. But you see, in that therapeutic category, there's only 2. Okay. Or the same with intermediate acting, there's only 1. If I look at the long, now I'm down into 3, and in the pre-mixed, there's a lot of different choices there. So you get the idea that in order for somebody to be covering all of those versus just 2 of them. And we have tiers. So funny thing is that Medicare itself only calls out 3 tiers, okay? Tiers 1, 2, and 3. So they would call Medicare's drug tiers are, tier 1, they call it lowest copayment, most generic. Tier 2, medium copayment, preferred brand name. Tier 4, higher copayment, non-preferred brand name. And then they can be specialties. Okay. Now, this is the typical that I see in many of the plans out there, tiers 1 through 6. Okay? And that's a bit different than what Medicare itself called out. Remember, they said that you had to have the 3 as a minimum. So now we've broken out the generics from the preferred generic to simply generic. Then we've got tier 3, preferred name brand drugs. Now the funny thing about tier 4 is it just says non-preferred drugs. Could be generic, could be name brand. It's just on the non-preferred list. Then there's the specialty drugs. And then tier 6, if they have that, that's not a common tier, I should say, tell you. It's will be addressing how things would be covered in the gap. Maybe they'll cover many of those common maintenance drugs still with the copay while in the gap, instead of charging the 25%. So to give you some ideas, typically on a plan you'd see tier 1 could be $1 or so, tier 4 maybe $4 or $5, tier 3 $35, tier 4 you'd be looking at maybe $100. Tier 5 could be 1/3 of the cost of the drug. Like I said, tier 6 is usually just trying to keep you with a small copay during the gap. And now Medicare has a late enrollment penalty if you don't sign up for Part D at the very beginning. And the way that works is the actual wording that you would see is it's going to be calculated when you first join the drug plan, and to estimate your penalty, and I stress estimate because the official will be calculated by CMS. They actually have more information than you have, and typically stuff that the customer may have received in the mail and didn't know what it meant and blew it off. I can give you the classic that happened to me. I had a customer who was in an old Plan J, and it had really, through attrition of the members in the plan and all that, it reached a point where for him it was almost $700 a month to maintain his Plan J when he could get a Plan G for $250 a month. Okay, but now he had to get a separate prescription drug plan. It's just that he had been in that J for almost, since he was 65, and then he was now 90. So, we talked about it and what the differences were and how much money he'd saved and all of that. So, but now your drugs will not be covered like they were in Plan J. And so we signed him up for a drug plan, and lo and behold, he's contacted for a late enrollment penalty. And so he comes back to me. How come I got this late enrollment penalty? And I said, well, let me see the letter you got from CMS. CMS, really spells it out. About 3 years prior, he'd received a letter in the mail, blew it off, that said that his Plan J drug plan was no longer credible coverage. And so he didn't do anything about that. He stayed with his Plan J. And so now that we were switching him, he had that 2.5 years worth of penalty added. Now, it wasn't a whole lot. That's what you'll see as we talk about it. Here's this as the calculation is 1% of the national base beneficiary premium $33.06 for 2021 times the number of full uncovered, etc. Like he says, they'll calculate that out. I tried using 33 cents a month, count the number of months, and they'll give you a pretty good estimate as to what the cost would be. So you figure in 10 months you're at $3.30. In my case, the guy was a little over 2 years, and lo and behold, his penalty was around $6.50. Okay, so not too bad, but that's going to continue forever, until he passes away. Right? So that's going to be a lifelong penalty. Now, we do have a program out there that we need to address here, and we will literally do a separate webinar on extra help. But for now, just know that this is a program that's available, also known as the low income subsidy. And this is for those people who just don't make a lot of money. And as we'll talk even more, it'll reduce their out-of-pocket cost. If they did have that penalty, it'll go away. They'll give them a copay in the gap instead of the 25%. And it's also for you an SEP opportunity, although we're gearing up for the AUP, so we're not really looking at SEPs right now. Okay? So that's what the extra help will do for you. To qualify, you have to be low income. And this is what the federal government, remember, not the state, which is Medicaid, this comes from the federal government, defines as low income, making less than $19,320. Now that equates to a Social Security check of about $1,610, okay, for a single person. And really, break that down even further. The average check out there is around 15 something. Okay, is the average check. If you Google it and see what the average Medicare check is, or the average Social Security check. But that's really not a good measurement, because that's just simply the average of the most expensive, people getting the most and those getting the median, the minimum, which is like around 250. Okay. So when you average that out, it comes out to a little bit more than this. If you go to the mode, in other words, instead of what's the dead center average, where is the weighted bottom, you'd find that it's around $1,400 a month. So that most of the people, or more than half the people who are drawing Medicare, are going to fall below that $1,900 a year in income and qualify for extra help. Well, that's just half the qualification. The other half is you can't have any resources. In other words, money in the bank, greater than $14,000. Now, imagine somebody only making that amount of money each month having any money in the bank. Remember that half the country doesn't even have $1,000 in the bank. So you can see that that's not a big hurdle for most of them to overcome. Yeah. When we talk about resources, here's what they need. And so a lot of things don't count, but let's look at what they say. If you had real estate holdings, not your home, your primary residence, but if you own real, rental property, that would count. Stuff like that. Bank accounts, stocks, bonds, mutual funds, retirement accounts, even cash stuffed into the mattress. That's what they count as a resource. They don't count your primary residence, so you could own your home. Personal possessions, vehicles, anything that's not readily converted to cash. When they talk insurance, we're really talking term life policies here, and any prepaid burial expenses. None of those are going to count as a resource. So I know that here where I live in Oregon, you could easily live out on a farm, own the farm, so you own your residence, and you're living in poverty, right? Because you got the minimum Social Security check, and these are things that you don't have. I mean, so many of those people are eligible. They simply, inherited the home from their parents and continue to live there. They also get a special enrollment. Now, that special enrollment is good for each quarter until the fourth quarter. And as we're getting ready to enter into the fourth quarter, that having extra help isn't going to help us out, because in the fourth quarter, AEP rules apply. In other words, any change that you make from 1 October forward goes into effect on 1 January. So in order to apply for extra help, you can go right to that website, that's socialsecurity.gov/I1020/start. Take you right to the application. It's pretty simple. There's provisions in there for us that, I wouldn't say do it for our customers, but to help our customers with it. So I've sat down with many a customer and did this application with them. The only requirement is that I will indicate on the application that I did that as their agent. Okay. So when you do that with them, I always just did the SOA at that time, and I made that appointment for about 30 days away, 35 days. They should have that letter back by then. During the webinar on extra help, I'll show you that there's even easier ways to do that. As I've always, I love to make that phone call to my customer. Hey, I've got some great news for you. We've got that extra help set up, so let's get together and do that application. So that's Part D. Now let's move on to Part C, the Medicare Advantage. We had talked before that there were two paths for people to get coverage in Medicare. The path on the left is what we were initially talking about here, where I get my A and B, and then I get a standalone prescription drug plan. Some people stop there, and others decide to supplement that with a Medigap plan. Now we're going to go to the column on the right. I still had to get A and B. That never went away. Okay? I still have that requirement. But now I'm going to enroll in a Medicare Advantage plan. It will most likely include Part D. I'll show you some instances where it may not, but for the most part, we're going to include Part D. And at the end of that, I'm done. I can't get a Medigap to cover whatever gaps are left. I can use a hospital indemnity, but that's it. Now, what happens here now is I'm going to get my Medicare Advantage plan from a private insurance company, United, Humana, Aetna. Okay, I'm going to go out, Blue Cross Blue Shield. I mean, there's all kinds of them out there. And the one thing that they have, two things that they have in common. One, they're all private companies. And number two is they're approved by Medicare. Okay? Not recommended, simply approved. Okay? They say that they meet all the requirements and they are approved by Medicare. So we would call that an alternative to original Medicare. And even that's not even a kind of a misnomer, because technically the client has still got original Medicare. The only difference is instead of Health and Human Services paying the bill, your private insurance company will be paying the bill. So the key thing in there to remember is anything that is covered by Medicare is also covered by a Medicare Advantage plan. They cannot choose to exempt anything. They're all going to have the same coverage, and it's whatever Medicare covers. Now, frequently, we're going to find that they're going to pack in a lot of extras, and that's just because of the competition in Medicare. So they're intended to completely replace A and B. However, you have to maintain paying your Part A if you had a Part A premium and your Part B premium. Those don't go away just because you get a Medicare Advantage plan. Okay? And you can't have both. I can't have original Medicare and Medicare Advantage. In other words, I can't get the federal government to pay and the insurance company to pay. Yeah. As we say here, that they will usually include Part D coverage. Now, when they do that, and they include that, we're going to call it an MAPD. But your plan is literally two plans together, kind of housed together. I can have a zero deductible Medicare Advantage plan and still have, $150 deductible drug plan together. Okay? Whatever my max out of pocket, because my Medicare Advantage plan must give me a maximum out of pocket, but it won't apply to my drug plan, because remember, they operate under the troop. Every time I would go to catastrophic coverage, I never have a max out of pocket for drugs. Now, while we would say that most of these plans are available almost anywhere in the country, and I have to stress that, almost. That just like regular private insurance, it can be limited to a geographic area or subject to decreased out-of-network coverage, even depending on where you live. I always like to use the example of where I live. Okay, I'm out here on the West Coast. I can take that I-5 corridor that runs from Mexico to Canada, start down there at San Diego at the border, hundreds of plans available. Okay? So there's all kinds of them. As I go north, I get into LA, still got hundreds of plans. But the moment I pass through the AHCP Mountains and I'm going down the Grapevine into the Central Valley, I don't have all those plans anymore. They're just starting to really dry up. If you look up, what's available there along the I-5 corridor, you find that there are areas of no plans at all, or areas of one or two plans. And then I get up into the Bay Area, and now I'm starting to see lots of plans again. Sacramento, lots of plans. Large geographic, not geographic, but large populated areas. So we're going to see that. Once I get up north to around Redding, they're gone. There's nothing for that last 200 miles of Northern California. Going to the Oregon border. Start to pick up a few around Medford, pick up a few more in Grants Pass, Roseburg, and then they dry up again in Central Oregon until I get up to the Portland area. Now I've got 50 or 60 plans available. Enter into Washington. I'm starting to drop off there in Vancouver. In between Vancouver and Seattle, I'm in a dead zone again. No plans, very few plans. If I go out to the Washington coast, there are no Advantage plans available at all. Once I hit, Olympia, Seattle, and good up almost to the Canadian border, but that very top part up there, again, plans start to drop off. There's just not a whole lot of people or a whole lot of plans. And as we're in those large metropolitan areas, we're going to see lots of competition. So while these plans are really going to start packing in the good stuff, so to speak, right? No deductibles, smaller to no deductible on the drug portion. Lots of things like gym memberships, over-the-counter drugs, meals after surgery, rides to and from the doctor and the pharmacy. I mean, they can really start packing in those benefits in some of the large metropolitan areas. I use the West Coast as an example. I could have just as easily been on the I-95 corridor, starting down there in Florida and gone north. There's areas with lots of plans, and there are areas with no plans at all. And in the areas with lots of plans, they try to draw the distinction from plan to plan by packing in more and more benefits. Okay. So if we just tried to compare the two, and we're talking original Medicare versus a Medicare Advantage. If I'm on Social Security, typically my enrollment in Medicare was automatic. My card just showed up in the mail. I want an Advantage plan, I actually have to go out and take action to enroll. There's, my renewal can be automatic, good. But my initial enrollment, I literally had to go and do something. Under original Medicare, I'm going to find that about 93% of all the doctors take Medicare. If I go over to my Advantage plan, if I got into that HMO in a lightly populated area, I could be really tight on who I can go and see, what doctors I can use, what hospitals I can go to. And so you can see there can be some differences in there. Original Medicare doesn't cover that dental, vision, and hearing at all, whereas my Advantage plan most likely will do something in almost all three of those areas. Again, back to my population areas, my dental could be everything from preventative only to $2,000 a year towards anything. And my vision can be not covering it at all, up to $300 for glasses. The hearing aids could be, again, nothing at all, up to $2,000 per year coverage. So Again, Medicare Advantage is going to pick up a lot of that stuff. My original Medicare doesn't provide any drug coverage at all, except for what comes with Part A and Part B, okay? Where I have to go and get a standalone prescription drug coverage if I want it under original Medicare, where in Medicare Advantage is probably going to be included. A couple of cases where it's not, and we'll actually go out and market to those, will be things like veterans, Native Americans using tribal health. Okay? And those are some two groups out there that are very specific that can be marketed to. Gaps in coverage, I get a Medigap available under original Medicare, and I've got smaller gap coverage, but I can't get a Medigap to cover that with my Advantage plan. I'm going to probably have to go and get a limited medical plan, which I always offer with my original Medicare has no limitations on where you are in the country. Now, you do have to be in the U.S. or U.S. territories to be covered. And my Medicare Advantage can limit my geographic coverage. I've got emergency coverage nationwide. In fact, some of them will even help me outside the country. But always remember, even if I get coverage outside the country, I have to pay the bill and submit a claim, because nobody outside the U.S. is going to bill my insurance company. Okay? Our doctors all do that. Foreign doctors do not. Enrollment periods. Okay. Now, this is kind of coincides with original Medicare, but it also goes with my Medicare Advantage plan, okay, and my Part D plan. So the initial enrollment period is 3 months before the month of my birthday, okay, and 3 months following my birthday. So I've got a 7-month window. Now, here's kind of one of the oddballs. Remember that we said for prescription drug coverage, I couldn't go without it for 63 days without incurring a penalty. Well, this is kind of the exception here. My initial enrollment, I could have gone to the end of my 7th month, right? So it puts me beyond the 63 days. And I would not have incurred a penalty for that. So initial enrollment, this is the same as for Medicare itself, also applies to initial enrollment in the Medicare Advantage plan. Now, Medicare Advantage plans also has what's known as the Medicare Advantage Open Enrollment. It's a little bit of a misnomer because it's not truly an open enrollment. I must have a Medicare Advantage plan, and I can change my Medicare Advantage plan. And you'd say, why is that right after the annual enrollment? Well, the reason is this is kind of what could be buyer's remorse, or it could be to help our customers here. And the concept is I enrolled and made a change back during my annual enrollment. Okay. And now I find here in January through March, in that time period, I went to go to the doctor, and I found that I changed plans, but guess what? My doctor's not in the plan. I thought he was. I tried to look him up. I made sure, but doctors leave and all the time. And lo and behold, I need to make a change. I need to get back to that plan that has my doctor in it. My plan was with Aetna, and it automatically renewed. And 1 January, my doctor stopped taking Aetna. Okay, so now I need to go get a plan from Humana or Blue Cross Blue Shield or whatever in order to be able to see that doctor. Okay. So as you can see, lots of things can happen that all that revolves around having making a change during the annual enrollment. But the key thing is I had to already have a plan. I can't decide in January to go get an MA plan, which is what it almost sounds like, right? It sounds like it's an open enrollment to get an MA plan. No, I had to already have one, and it's an opportunity to change it again. So that's January through March. And this is the one that we're all gearing up for, the annual enrollment. Okay, and this lets anybody who wants to make a change. It could be on original Medicare and I want to get a drug plan. I'm in a Medicare Advantage and I want to go to a different Medicare Advantage. I'm in a Medigap plan, and in January I want to drop my Medigap and do a Medicare Advantage plan. I mean, all those different things. Statistically, from the numbers that come out of CMS, 1/4 of the people on Medicare will make a change. Okay? Some people just tend to do it every year. Don't know why. I always discourage it. I encourage everybody to look at their plan every year, but not necessarily change their plan. They should at least go ahead and look at it then. So as we prepare for AEP, we've always got the agents, and those can be going on throughout. If I had somebody that was aging in November or December, I would definitely wait until October to enroll them, because in 1 October is going to bring out the new plans for 2022, and I might want to be able to. I don't want to enroll them in a plan that disappears next year, right? So I want to kind of be able to, and I have that opportunity for people in November, December. In October 1st, when I find that the plans I put customers in are going away, I'm going to contact those customers to put them in new plans. But that's more of the switcher, okay? So switchers, okay, this is that 25% that's out there. Maybe they've been in that plan that had a premium, and they see all these 0 premium plans, and they want to maybe switch to one of those. Like I was talking about for the agent and why I waited until October to do a November enrollment, because that plan exited the market. Okay. In fact, an example would be this year. Aetna has plans in Central Oregon, but they're exiting the market next year. So any of my customers that are in an MA plan in Central Oregon, I'll be calling in October to find them a new plan for 2022. Okay, sometimes there's consolidations. The elimination of the first dollar coverage, that was those who can't get a Plan F anymore. New product offering, new benefits, the provider exits. We talked all of those, moves to a new address. That's typically more of a special election period, but maybe they didn't do it during the special election that they had, and they've been without a plan. Okay. So special elections, those are kind of like the top 4 there, right? There are literally hundreds of those. And in December, our first plan following the close of AEP will be special election period. So we can look at how we're going to service people going into the next year. Yeah, like I said, special enrollments, those are things that, have some kind of a change. And this is what I told you on that last slide. These are the biggies, right? And that's why in December, we'll go over that big list. You can find them all on Medicare.gov. The best source I've ever seen is United Healthcare has a book, or I should say pamphlet. It's about 50 pages long and talks all the SEPs that are out there and what the requirements are. Like I said, and we'll go over that come December. So now many people now are working well beyond age 65. And if they've got that coverage through a plan at work, great. So they can, get their IEP later. Okay, I shouldn't say that because their IEP still stayed at age 65. They call it an ICEP later on. Okay, so they get your IEP at 65, and maybe they want to stay and work and just get their Part A. Sometimes they don't do anything at all. I always just recommend that they get Part A. And if you're in a group that's got less than 20 employees in it, you may not be able to delay that Part B because small business rules are different than the big group plans, and they are not required to provide coverage for those that are Medicare eligible. And then once that plan goes away, you can do it anytime. You can leave the plan yourself, or the plan can terminate with your job, but you've got 8 months. That's a huge time period. 8 months to enroll in Medicare, and that is the only SEP for enrolling in Medicare, loss of group coverage, that you could do that without any penalties. Okay? And if your Part B coverage was at the end of that 8th month, you'd have another 6 months to get a Medigap plan with still using the guaranteed issue. Okay, so just little facts and numbers to keep in mind. And that's what I've got for you here today. If anybody has any questions, I always like you to just go ahead and email them in to me. You can reach me at training@ahcpsales.com. And you guys all have a great day.